Welcome to the Moulding Health Show. Our goal is to leverage the wisdom and experience of healthcare practitioners to set you on a path of self-discovery and healing. These insights, coupled with a multidisciplinary approach to each area of interest, should provide an invaluable resource to everyone looking for a better approach to health. In this episode of the show, we speak to Samantha Campbell about cerebral palsy and the MAES approach from an occupational therapist perspective. Samantha Campbell, welcome to the show. So we're so glad to have you on board and speaking about cerebral palsy and the MAES approach. Welcome on board.
Thank you, Oliver. Good to be here.
No, I mean, like it's so good to have you on board. And we've never touched this topic at all in any form. So I'm really glad to unpack it with you. And maybe just to kick it off, because we were speaking just before the show and I said, so cerebral palsy, I mean, they normally say CP, right? What is it firstly? Because, I mean, if anyone doesn't know what it is, what would that be?
Yeah, so the word cerebral palsy, cerebral means brain and palsy means loss or impairment. So when we talk about cerebral palsy, we're basically speaking about a collection, I guess, of conditions that result from injury to the brain. So it's a brain injury that results in a whole bunch of impairments.
That actually makes a lot of sense. And my next question, because I'm absolutely fascinated with what OTs do, because your scope seems to be so amazing. You know, like I would have never put like mental health with OT, you know, until like a few years ago. But now I do know that. But it's amazing. So how would an OT help with CP?
So that's quite a complex question because, as you know, like OT covers quite a wide variety of diagnoses and illnesses and injuries, because basically the main aim of OT is you understand a person and their injury or illness or diagnoses and how they are unable to participate in the activities that are meaningful to them, so their everyday activities. So when you look at somebody or child or a baby who has a brain injury with cerebral palsy, you're looking at how that brain injury is stopping them from participating in everyday activities. So it's complex in the way that if I had to answer this question 5 years ago, I would have had quite a short-term approach to how I would treat a child with cerebral palsy as an occupational therapist. I would look at how to get them participating into daily activities, into how do they dress, how do they eat, how do they walk, how do they communicate. Now, like being an OT for a longer period of time and working with children with cerebral palsy for about 6 years now, my approach is slightly different, and I more approach it, and I know that we'll get to this, but my approach comes from a MAES perspective. So I'm more looking at the long-term neurodevelopment of the kiddie and treating them from that perspective, as opposed to the short-term functional participation, if that makes sense.
Yeah, so I suppose you got our curiosity going with the MAES approach, and so we have to kind of touch onto that now to make it, you know, for it to make sense. But I like what you're saying in terms of, you know, one is much more long-term and the other one seems more, you know, remedial and short-term. So yeah, I love that. But tell us, what is MAES?
So MAES is basically an approach or a framework that looks at the long-term neurodevelopment of babies or children with neurodevelopmental problems. So it understands a child from a brain perspective, basically analyzing their movement, their behavior, how they are doing things. So you analyze that and you're basically understanding where is there like a lack of skill or a lack of quality. And when you see a lack of quality, you understand that that child or that baby has specific brain skills that are missing based on the area that's damaged, so in the brain where there's a lesion. And then your therapy basically targets trying to provide them with opportunities to learn brain skills that will take them further long term. So that's the MAES approach in a nutshell, but it's a lot more complicated and complex than that. I must say that I'm still a novice in this area. Like I did my MAES training 4 years ago, and I've been practicing for the last 4 years, but it's a completely different way of thinking to what I was exposed to at university and different courses that I have learned along the way. And it really has taken time to adjust my thinking. But it basically, just to explain a bit more about MAES, it started from a man, his name is Jean-Pierre MAES, and he is working in the UK at the moment. He was a Bobath tutor. And how the sort of MAES approach developed is that he was analyzing his children, analyzing his therapy, taking videos, analyzing what he was seeing, and basically starting to understand it from a different sort of perspective to what he had been learning. And he was adjusting his therapy in how he was analyzing it. And when people were asking him what he was doing, he was still teaching from a Bobath tutor perspective. And there was sort of a mismatch between what he was teaching and what therapists or colleagues were seeing in the actual therapy. And they were saying like, hey, Jean-Pierre, like this isn't really matching up. What is happening here? And then he started also understanding that. And from there, the MAES teaching started. So yeah, that's basically MAES in a nutshell.
Okay.
Yeah.
And the other term you use, but this is the amazing thing is like the lingo is so different, with practitioners. Is the Bobath tutor, is that another approach to it?
Yes, so it's NDT Bobath. I think you'll be familiar with NDT. That's a common one in South Africa also, globally and in South Africa.
Okay, yeah, we're very familiar with the NDT, especially with sensory integration and the kiddies, physiotherapists and stuff like that. So okay, so Bobath is a tutor is very similar to that then.
Yes.
Okay, yeah. That makes sense. And so is Jean-Pierre, is he an OT as well?
He's actually a physiotherapist. He's Belgium, but he's working in the UK as a physiotherapist.
Okay, that's interesting. It's actually so interesting that he would have taken that, hey, and then just come up with his own approach. That's actually
just on that, because like often people say that like, oh wow, you're an occupational therapist and you're learning from a physiotherapist. Is there like a bit of a mismatch there? But I think just understanding cerebral palsy, and as we said in the beginning, it's a brain injury that results in impairment. And if we're looking at it from a brain approach, because the problem is the brain, I think that we could sort of agree to a level that if you're a physiotherapist or an OT or a speech therapist, and you're analyzing it from a brain perspective, your therapy should actually look quite similar, because it's not like you are looking at the muscles or you're looking at just the function, you're looking at the brain. So that's why it makes it understandable to be able to learn from a physio for a speech therapist to also be doing similar things from a brain perspective.
That's actually interesting. I would have thought it's like a neuroscientist or like someone that specializes in the brain, that would have come up with that. But that's actually incredible, that story. And I have to ask, so how accurate is it? Because anything associated with the brain and even the body, I suppose, it's like very it's very complicated. People understand that and stuff like that. So do you find that the analysis of the brain, from the MAES approach, is it pretty accurate in terms of what you need to do then from a therapy point of view?
Yeah, so what I've found in putting it into practice is that we understand what typical behavior looks like. We understand typically how your muscles need to work to function well, what cognitive processes should look like. So we understand typical development. So for us, when we are analyzing a child and we see quality of movement that is poor or looking atypical, and we analyze that thoroughly, then we start to see, okay, if we are analyzing it thoroughly, we can understand where there's a brain skill that's missing, because we're seeing the behavior and we're going back to our videos, we're analyzing, we're seeing exactly what the child is doing at certain points in response to us. or in response to an activity. So we can see at that point, okay, there was a change in the quality, or there was a change in the behavior, which allows us to then understand, okay, what's happening on a brain level in that moment that's making that behavior or that movement or what we're seeing, what is making that there.
That is fascinating, hey? I mean, that's, yeah, the word that I was thinking was phenomenal. That's because for a long time, I mean, we've got two children, and, you know, I was thinking you almost have, I would say, almost like a blueprint, you know, of where they should be and where they, you know, like they can be. And then you kind of work backwards, you know, from there. And what you're saying is kind of correlates, you know, with what I was thinking is, you know, that's how it should be happening.
Yeah.
But I love that. That is
Yeah.
incredible.
I think what just on that, like what helps so much is that in the moment we analyze on a surface level, but what's really helped me is and what Jean-Pierre is a huge advocate for, and the MAES approach really encourages us to do this, is to video our sessions, because often in the moment, therapists, I think you can get overwhelmed, you miss certain things, and you go back to your video and then you see things, you see the child respond at a specific time to a specific thing, and your understanding of what's happening on a brain level is just like taken a lot deeper. You know, I think before I had been trained in MAES, my level of, I guess, problem solving or understanding was very surface level. I used to look at things like tone, strength, joints, like all of those sort of things, and think that the problem lay there, where in actual fact, when you analyze further, and you know, we all know that it's a brain problem, you analyze it further and then you see, okay, it's not a problem with tone, but why are you seeing that in that moment? What is happening? So I think that's been like the biggest learning curve for me.
That is incredible. Yeah. I mean, and again, I mean, like, you know, it's amazing that all of this, you know, like, you know, this information is out there, you know, with practitioners. And I think, you know, that's you know, the big reason, you know, we want to do something like this is because of exactly this conversation, is because that makes complete sense to me, you know, like as a, you know, like as a analytical type person, you know, that makes sense, you know, like in terms of what it is. And having two children and them going through, you know, the assessments at various stages, you know, I know that's kind of what comes out in those assessments, you know, the tone, the, you know, sometimes the exercises. I like how you said video as well, because that, for me, you know, like even with our own team, you know, as a company, you know, I find, you know, just the fact that we do it on Zoom and we can refer back to it, it's actually amazing, you know, like the world that we're living in. And I think also for a parent, you know, when you can show the parent, actually see, you know, he did this, and that's probably correlates to this, that must be amazing for your patients.
Yeah, definitely. I love the video part as well, because then in my reports or my feedback to the parent, you can actually like screen grab the exact moment where you see the loss of quality. You can say, this is what's happening right here. You can see your child, how they're responding, which is very helpful, I think.
No, that is incredible. And just going back to the cerebral palsy stuff, though, is how is it diagnosed? I mean, does it come from a specific type of practitioner? I mean, how does someone actually know that they have it?
Yeah, so this the area, I guess, of diagnosing, I think that we are a bit behind. It's normally the normal process is that a child like born at risk, in at least in the government hospitals. So if they are born high risk, so if they have a birth trauma or low APGAR scores or jaundice, there's normally a list of high risk factors. Then they put onto an almost like a high risk baby program. So they come back every 3 months, and their development is monitored. Often in private as well, if they are discharged with high risk factors, they will be booked for a follow-up, where the I guess the pediatrician will see them for a follow-up. But often what happens is that if there was sort of brain trauma, if the parents can't afford to do like an MRI or like a brain scan, the doctor will say, okay, or the medical professional will wait to see if symptoms or presentation develops. So before diagnosing cerebral palsy, people normally wait to see if symptoms develop. And then only at 1.5, 2, are we getting the diagnoses of cerebral palsy. So that's sort of what's currently happening when doctors are being able to see, okay, there's a clear atypical developmental pattern happening here. And then they are diagnosing CP. If they can have the brain scan before and they see that there's a brain injury, then they can diagnose it earlier. But what we are seeing as well is that there's an assessment called general movement assessment. So it's Prechtel's general movement assessment, which is basically an assessment that's done between the ages of 0 and 3 months, and then 3 months and 5 months, where professionals, medical professionals that are trained in the general movement assessment use like a visual perception to analyze a baby's movements. So you understand what a normal baby's movement should be based on their like neuroactivity. And then if you are seeing something different, you can conclude that there's something that's atypical going on a neurological level. And that is actually that's got a higher predictability for cerebral palsy at the moment, but it's not being used everywhere. So currently in Johannesburg, it's being used by a lot of therapists. In Durban, we are a bit behind,
Okay.
as well as Cape Town. So Joburg's like it's being used the most, but it's like it's a non-invasive and highly predictable like assessment for cerebral palsy that I feel that we're not using fully.
And when you say that, Sam, I mean, is it, you know, that based on, I mean, are there certain OTs that specialize in MAES, and, you know, you have a certain group, and obviously you interact as a community of professionals around that stuff? Is that how it works?
Yeah. So if you do the training, like for me, I was very lucky to have done the general movements training as well, and the advanced general movements. And you can go we have a little WhatsApp group, and you share videos.
Okay.
You ask for different opinions because it's based on your perception of the baby's movement. So it's very helpful to have other people's opinions. So you often are communicating with a community of trained professionals. So you're seeing where it's being done, you're seeing how it's being done and what's happening in that space. And it's the same with the MAES. We have groups, we have TATs, we have like a community of MAES therapists that you're constantly asking for advice or opinions to try and improve your therapy and your understanding, your learning the whole time.
That is pretty amazing. And if I had to ask, I mean, is it a big group or a small group? I mean, and is it just in South Africa?
So it's globally. So for general movements, it's international. The trainer who came down to train in PE this year, her name is Dr. Einspieler. So she does training all over the world. So we're able to get feedback from things that are happening all over the world. She's doing a lot of work in India, the babies in India, and everywhere. So she feeds back a lot of that stuff to us. For MAES, it's international, but we have a South African group. But then we can be in communication with therapists all over the world. And what often happens is when we did our training, we had therapists from the UK join our training. When I did the MAES Advanced, we had about 10 therapists from all over the world that joined that MAES Advanced training. So we have a big group in South Africa. I'm not sure how many MAES therapists there are in South Africa at the moment. I know in Durban there's only 2.
Wow.
So it's really little. It's growing, like the MAES community is growing, but it's small, and it's often feels, I guess, a bit lonely. But it's growing, and it's cool to know that there is a community, but it's like an online community, and it's a bit far.
I think what I like about that is it almost, you know, especially with the worldwide, you know, slant to it, it makes you feel like you're a bigger, part of a bigger community, which is amazing. It's like, because then
Yeah.
you can feed off like experiences. We speak about the UK, being, first world country and, access to, other facilities, but it'll be nice to see, your experience as a therapist, and the
Mm,
experiences of a therapist in the UK or in India, as you said, or, the US, it must be amazing.
yeah, yeah, definitely.
Hmm. I have to ask though, because you said 0 to 3 months, and at that time, most parents are actually so smitten with their little one, and they're not really sure if something is going wrong. Like how would someone actually reach out? I mean, how would you know that the little one has a brain injury? Because I mean, I'm just thinking of our little ones. I mean, I don't think we would have picked that up. So, is there a certain thing that kind of prompts them to say, actually, I need to get more help?
Yeah. So in Australia, it's actually their protocol. Is basically if a child is born high risk, so any of the high risk factors, they have to have a general movements assessment. So, but before they leave the hospital on their 6-week checkup, they have a general movement assessment. In South Africa, something like when the child, if a child say is in the NICU or spends time in the NICU or like has had a traumatic birth, it should be the pediatricians or the neonatal nurses that are saying to the parents, okay, this is a high risk factor. This is the certain things that you can look out for. These are the people that you should be contacting to have a follow up. But those systems don't exist. Like well in Johannesburg, like in certain hospitals, those systems are well in place. So there's good relationships between the therapists, the doctors, the neonatal staff, that they know, okay, this child has had a high risk birth. They need to be followed up by the physio, by the OT, by the speech therapist. Whereas in private, it's very difficult to get that sort of thing in place. Because yeah, I don't know how, like a parent wouldn't know um what to
No,
look for, what to do,
no.
unless as they are discharged, they sort of get a pamphlet or
Mm,
information shared with them from the person discharging them or from people that they've interacted with during their time in the hospital, that will say to him, guys, this is what you need to be looking out for. If your baby is feeling stiff, if they're not moving in a specific way, we need to be making an appointment with this person.
mm.
I don't know how how else.
Yeah. I mean, it sounds like such a difficult question, and yet, I just think of the last few episodes we had. We had Shelley Hall, from a clin psych point of view, talking about postpartum depression, and it's such a common thing with women, and yet, I think what we're talking about here is more that proactive measure. If there's an issue, and maybe even just mentioning it, but people don't know that, so just, someone just picking up their hand and saying, please note, that 5 out of 7 women, suffer with postpartum depression. And that's not true,
Mm,
by the way. I'll just pay that up. But if it was the case, but, we had Samantha Harding from a physiotherapist point of view, talking about again that antenatal and postnatal stuff. And she was talking about pelvic floor physiotherapy. And stuff like we don't really know, and so if some, like a lady's going through that, after pregnancy, like how do you reach out? And I think what you're saying now kind of makes sense as well. It's more that proactive measure. Because my question would be is what is high risk? The one thing I would say probably is if it's a prem baby, premature, probably that would be high risk. Are there
yeah.
anything else? Mm.
Yeah, definitely. So high risk for me would be if the mother had experienced infections during pregnancy. Um, so there's a whole bunch of different sort of infections that can affect the developing brain. Chickenpox, syphilis, um, yeah, rubella, like different infections can affect the baby's brain. So if a mother had complications during the pregnancy, the baby is at high risk. If there's placental problems, they can cause development abnormalities. That would be sort of a high risk. Severe jaundice, as you said, preterm delivery, low birth weight, um, like a traumatic birth, if something's going wrong, if the umbilical cord is around the neck, if there's a lack of oxygen to the brain. Those are all sort of the high risk things that are common in our setting.
Okay, that makes sense.
Yeah.
I mean, I like that. And like I said, when we transcribe this up, just listing those. So if anyone says, okay, yeah, that actually happened, maybe I need to seek help right now, I think would be amazing. Like you said, Australia seems to be ahead of the curve. And I think if you had more, pointers like that, that would be amazing. But, I think for the most part, we don't have that. So it's up to parents, to or maybe ask the right questions from the right practitioners and say, should I be doing this? Should I know what a general movement assessment is? Because until 30 minutes ago, I didn't know what that was. So,
you and a whole lot of other people.
So that's been the amazing thing about this journey, with practitioners for me, is learning all of this lingo that I, would have never found. It's not in my vocabulary, and that's with having children, and actually working with practitioners. So one would think I should know some of that, but we don't. And I want to know what to put in Google as well to find that out. And what you said, and the one thing I do know, like especially with the sensory integration stuff or early development, therapists, they all say, the sooner you catch it, the better it is, the prognosis. And what you're saying seems to collaborate that story. Is that true?
Definitely. 100% true.
Okay, cool. So I wasn't too far off the money there. And so I think if you know that, and you can get connected with like a MAES therapist like yourself, then you have some good guidance around it.
Yeah, especially just on that point, Oliver, like if you look at the brain, and if there's an injury that's taken place, the way that the brain develops after that injury. So you have a child with the rest of the brain is healthy most of the time. So there's an injury that's occurred in a specific part, and now how that the child develops from that point where the injury has occurred, their brain is going to solve problems in a way that compensates for where that injury is. So the atypical behavior that we see is how that brain is compensating for that injury. And if we can get hold of that kiddie from before those compensation strategies are too far down the line, we can change the way, thanks to neuroplasticity and the incredibleness of our brains, we can change the way that brain solves problems to take that kiddie a lot further neurodevelopmentally.
Wow. That gives me goosebumps, because that is incredible. I know, like with our little boy, I can't remember, but I think he was like 2 or so. And I think he probably just twisted his ankle or something. But over the next, day or so, he compensated, but he was like almost like dragging his foot, it's just like we just get, we get used to stuff like that. And, after a while of seeing him do that, we obviously went and saw a physio for it. But it's, when you say that, it's actually true. And I think for the little child, they don't know why they're doing things, but the brain is almost like help them navigate through that in its own way of survival, which is pretty amazing.
Yeah.
So very cool. The other thing that kind of comes up a lot, when we started doing research for this topic, is they ask, are there different types of cerebral palsy? Is there any merit to that?
Yes, definitely. Okay. So I think because we understand that it's a brain injury, it depends on where the brain injury is that affects the presentation that we see. So the 4, like, I guess, most common types that we've grouped is basically spastic. So that's where you're seeing kiddies commonly or traditionally diagnosed with like an increased tone. And that's broken down further into where you're seeing this increased tone or increased tension, because I don't like the word tone. Okay. But it's then broken down into spastic diplegia, spastic hemiplegia, or spastic quadriplegia, depending on what area of the brain is what area of the body is seemingly most affected. Then you get your athetoid dyskinetic, and those are the kiddies that often have a brain injury associated with the basal ganglia. So the basal ganglia is like our central switchboard. It allows like basically for me to be able to reach, like my brain is saying, okay, at this moment, this muscle can relax and this muscle must contract. And my brain is allowing that switch to happen. So the whole time we are participating in different activities, our basal ganglia is like the switchboard that's allowing that. So often we see our dyskinetic kitties are like switching fast between different positions, and that's because they have a problem with the basal ganglia. So that's a type of cerebral palsy, is a dyskinetic presentation. The other one is like a hypotonic, and those are often our kitties that come across as quite floppy. And then the last one is like ataxic. And that's often like when you see an ataxic tremor, and that's often got to do with injury to the cerebellum, which is part of the brain involved in our movement, our feedback, feed forward systems. So that I would say would be the 4 like most common, like classifications of cerebral palsy. But basically, if we know that it's based on a brain injury, then the types of cerebral palsy that we'll see will relate to where the brain injury occurs.
Okay. That kind of makes sense.
And that can look different because we understand that our brains are so complex. A child that has a brain injury in the white matter, so often our babies that are born prematurely, it can look completely different from one child with an injury in the white matter to another child with an injury in the white matter, because our brains are so complex and they develop differently.
Okay. And I know one of the questions we had was like, are more people, like are certain people more at risk, or certain babies? And I think you kind of answered that in terms of saying, like there's obviously, risk factors, and if that happens, is there anything around that though? Is it like a genetic, is there anything around genetics as well that play a role in this?
Yeah, so it can be genetic, especially if there's like a genetic mutation that causes harm to a developing brain. So anything that can affect a developing brain can result in cerebral palsy. So it can be genetic, but it's often it's unknown. There's not like enough, or there's not a lot of research into the exact causes, because there can be quite a like variable factors that can impact the developing brain.
It's like, the common one is stress at the moment. When I say at the moment, I mean for years now. But like I think everything, it comes back to lifestyle and stress. I suppose with genetics as well. I think we probably have, we're still not there where we can pinpoint that, clearly. But it would be amazing,
Yeah.
to be able to know actually you at risk, probably. So we have to keep that in mind. Yeah. And also, like, I think generations back, people didn't even know, they always knew, like, the child was probably different or something. And so they didn't pick it up maybe, as quickly as they did. And in my mind, I always have this idea that, children with CP, they can't really move well. Is that how it is as well? How do you know if someone does have CP? Maybe it's another question.
Yeah, so I think that's a common and easy to see presentation of it. And a lot of the kiddies that I see that have cerebral palsy can't move well. Their coordination, their ability to use their muscles in the way that is of good quality is difficult for their brains. So what you're seeing is poor movement, poor ability to coordinate those movements, poor ability to walk, to sit sometimes, to move on the floor sometimes, to like do a whole bunch of different movements. Sometimes they really struggle with that. But in the same way, some kiddies can walk normally, but they struggle with the cognitive processes of being able to plan, being able to have perceive something from another point of view. So sometimes the physical presentation of it, their movement is actually okay, but there's still a brain injury, so their cognitive processes are still affected. So I would say that often that you can see the movement is the problem. Often you see poor quality there, but you can also, the quality of the movement can seem okay, but there's a poor quality relating to the cognitive processes of that child. And that is also still cerebral palsy.
Wow. Okay. That's actually interesting. I don't think I've heard someone mention it like that. And you know, as you're talking about movement and, you know, the awkwardness sometimes of it, and how, you know, I mean, like, I think OT used to say this a lot, you know, the whole midline crossing, and, you know, that seems to be a common thing with children to know whether they can do this stuff or not. But the other one, especially speaking to this, you know, the speech therapist, you know, that comes up a lot is the whole dysphagia stuff, you know, the movement stuff. And is any correlation there, or is it like an overlap, you know, where children are not like that? I think dysphagia is like, you know, the whole movement, you know, where they're not as comfortable, you know, with certain things.
Yeah, so like dyspraxia and being able to move. There's definitely, I mean, if it's the brain injury, there's definitely an overlap in the different areas of speech and physio and OT that affect movement. And especially like if there's a brain injury that is affecting the ability to coordinate the movements of the body, that also means affecting the coordinates, the coordination of movement of muscles that are relating to the jaw and to the mouth. So talking, eating, all of those things are also affected by the brain injury. I don't know if that answers that question.
Yeah, no, it does. I mean, like, and I don't know, that's like a little bit, because obviously, I mean, like, you know, that seems to be the realm of the speech therapist as well. But I know that the two words that always seem to come up a lot is dyspraxia and dysphagia. And I think dysphagia, you know, the more movement stuff. But as you're talking about CP, and I like how you said sometimes it goes you know, like to the lay person, you know, you're not going to put it together, but you kind of see it in certain activities. And I find that, like, you know, with dysphagia, you know, like they can do most of the things, but when it comes to certain things, you know, they obviously can't, you know, jumping up and down might be one of those, or something.
What I find like amazing in what you're saying is that some of my kiddies, their brain injury has a massive impact on the way that they move their body. So they seem like very stuck. They have to sort of tense their muscles to understand where they are. So this particular kiddie that I'm referring to has a white matter injury. So she doesn't, her reference point, she needs external reference objects, if that makes sense. So she struggles to understand herself in relation to herself. So in her body and in her how she uses her muscles, she appears very stuck, because she needs to tense the whole time to understand herself. But the way that she can think and plan is brilliant. So she can tell me certain things, and how she can plan in her head is brilliant. Like, she's extremely smart, but the way that she understands her body and moves her body is very atypical. And that's where she, like, for her, that's the biggest thing. But her cognitive processing is incredible. So it's so interesting, because often you get these kiddies that have more of like a physical impact or presentation, but their ability to process and reason and think is so good. And then often your kiddies that might seem physically more typical might have like a bigger struggle to process and plan and judge and perceive certain information. So their like limitations are on a cognitive process much bigger than their physical limitations, but all coming from the brain.
That's actually incredible. Hey, I mean, but as you're speaking, I can't help but thinking like Avatar. I don't know if you watched the movie, but the new one is is coming out in like 2 months or something. I actually thought it's December, but it's actually in 2 months, or maybe even next month, which is September. But you know, there as well, it's like they get a new body, and as long as you have the brain to control it, I can't help but thinking like that. You know, like she really wants the body to do this, but she can't get it to do it, which is incredible. You know how that works. So Sam, so if you have this, so you did the general movement assessment and you know it's cerebral palsy, and I know you're coming from the MAES approach, but at that point, would a therapist or an OT, would they have different approaches that they can take in terms of helping the little one?
Yeah, definitely. So just like from a general movements approach, or from a MAES approach, I think it would look quite different to if you approached a kiddie from a sensory integration approach or an NDT approach. For me, if I had to receive a baby and that was like 3 months old, and I did a general movements assessment, and now I understand that something is not right in the brain. So on a brain level, we have a problem. Then my therapy would be analyzing the movement of the baby, and basically from at that level, at a 3 month level, providing opportunity for the baby to move in a way that is developing brain skills. Because I think what's also important to know, like for us as therapists, sometimes it's easier for us to treat symptoms. So when the child is older, we can see what's wrong. We know what's wrong. We understand what's wrong because they've had all of this time to develop these compensation strategies. So then you get the child later and you can clearly see. From when they're babies, sometimes you don't see what's wrong because it hasn't developed yet. So our therapy then is targeting at promoting what should be there instead of taking away what should not be there. So that's something that Jean-Pierre always says, like when we get a baby, that's like the proper test of the therapist, because now you're not treating what shouldn't be there, but you want to encourage what should be there. Which I think for me, when I had just come from varsity, with my knowledge from varsity, I would have approached it. I wouldn't necessarily know what to do with the baby. My approach would need to see symptoms for me to know what to do, whereas now my approach is very different to that.
Yeah, I mean, that is so profound. And there's so much of work around the brain at the moment, in terms of broadening the neural pathways and all of those things. And what you're saying now, it's almost like you're almost training the brain to think in a certain way because you're already preempting that it's going to think in a certain way. It's almost like, and that is
Yes.
it's pretty incredible.
Yeah.
Even before the
Yeah.
baby knows that they're going to hit this roadblock when they get to 1.5 and they can't jump, like actually, maybe we should be training them. That is pretty amazing, actually.
Yeah. And we were actually speaking about it. We did a MAES intro course last week, and Shane Brassel, she's a physio in Cape Town, she was actually talking about the concept of neuroplasticity. I think that's also like a common word being used at the moment, and everybody is really liking it, and it is an incredible thing. But we were speaking of it as also having negative effects, because the brain has the ability to change, and have all these new neural pathways, but it is most likely for the brain to choose the easiest neural pathway. So if you have a kiddie with a brain lesion, they're not going to choose a pathway that is more difficult for them, that could take them further. They will choose the pathway that is the easiest, which could lead to a sort of plateau effect. And I think that word, like the plateau sort of effect, is something that therapists working with cerebral palsy are very familiar with, because it's what we're seeing in our kiddies all the time, is that they sort of are reaching this plateau. And I think in varsity and from like a basic level, we sort of then adopt like a maintenance program or a preventing secondary complications program, instead of saying, okay, like why are they reaching a plateau? Like, is the child reaching a plateau, or am I as the therapist reaching a plateau? Because the brain should be able to continue developing if the brain, is still a healthy brain. So it was just like an interesting thing that, we were just discussing last week about neuroplasticity.
Yeah, no, that sounds like an interesting topic. And I think the one thing we do know as humans, I mean, we're always going to pick the path of least resistance. I mean, like, and the brain is like, the trigger, it's the heart of everything like that. It actually dictates, how you're going to do it. So yeah, that actually, it makes sense in my mind, how we do that. Very cool. The other thing that kind of came up was cerebral palsy in adults. Is that a thing as well? I mean, okay.
Yeah,
So
definitely.
does it show a lot?
Yeah, so obviously our kiddies with cerebral palsy become adults with cerebral palsy, and then you are way further down the line. And I think that's where the plateau sort of effect is more common, and where people are, sort of treat adults as like, okay, they've reached, we can't change things. It's more difficult to change things. And they sort of are saying, okay, well, we want to prevent secondary complications like contractures and different medical complications. So you take on a more prevention sort of role. But I've seen changes happen in adults with cerebral palsy with specifically with the MAES approach. I've seen changes that Jean-Pierre has done sessions, and there's been brain changes even when they are adults. For me, my oldest patient with cerebral palsy is 17, and we are seeing brain changes with that woman, with that lady. So yeah, you can it's more difficult to treat an adult because as you know, like the pathway or the neural pathway is more defined the older you get. So it's more difficult, but it's not impossible, I would say.
Yeah. I suppose you have to go with that whole, reasoning, and almost intellectually it must make sense, for the person to do it. Whereas as a child, they're almost like going to do it, because you're telling them to do it. So there's that factor, I'm assuming, as well with that. And do you find, are there certain symptoms with adults? Like so you said with children, there's certain, like you're going to pick it up on the symptoms, but with adults, do you find similar things like physical and stuff like that?
Yeah, definitely. So our adults so you won't diagnose cerebral palsy as an adult. Like cerebral palsy, the sort of traditional or definition is like a brain injury that occurs just before, during, or just after the sort of birth, within the first 2 years. So it's like the developing brain that's been injured. So our children that have cerebral palsy will grow into the adults that have cerebral palsy, but their symptoms could be worse. So they can worsen over time. So although the brain injury doesn't worsen, so the brain injury happens and that's that, the symptoms can worsen because, as we've said, if the brain keeps on taking the sort of shortcuts, that can lead to worsening presentation. So you find adults are often a lot more tense, or they have learned that if they want to move their muscles in a certain way, then they need to do certain things to be able to do that. So you often see adults that look a lot more stuck because their brain has compensated over a lot more years than our children's brains have been compensating. So the adults' presentations often look more severe in some cases. So often adults are in wheelchairs, or their arms are stuck, or they have, like their difficulties are slightly worse than what we're seeing in our kiddies.
Okay, that's actually, and I suppose then it would be a lot more noticeable as well, because with children, you like you always put it down to development, and obviously they're going to get there. But with adults, it's probably more fixed, and you can probably see it, a lot more if you know what you're looking for, which is interesting. So coming back to the MAES approach, Sam. So once you determine actually going to go down the MAES, with MAES therapy, are there certain things that you follow, and does it take a certain amount of time? Is it is it throughout the child's I suppose lifetime that they have to go for something, or is it like an intervention type therapy?
Yeah, so it depends on what the parents are able to do, what the capacity of the therapist. At the MAES Center in the UK, they have intervention weeks. So it's almost like a block therapy that's like an intensive week of therapy, or they have weekly therapy sessions, or they basically the parents sit in on the sessions. So the same with me, where I encourage my parents to be in the session. Often they are part of the session, so they can understand what I'm saying, what is going on a brain level, and then how do we respond to that in a way that is promoting brain skills, encouraging brain skills rather than not, so that they are learning their child's brain, so that they can take what they're learning in therapy and apply it at home, so that everyday activities could then have the opportunity to develop brain skills rather than not. So for me, how it's working at the moment is, if I assess a kiddie, my assessment, I video my whole assessment and then understand the child on the brain perspective. Then I say to the parent, okay, here's where we're seeing a loss of quality. Because we're seeing a loss of quality in these moments, this means that in this moment, the child is using compensation strategies. So we know for this task that would require this brain skill and this brain skill, they don't have that. So that's why we're seeing the loss of quality. So if we're seeing the loss of quality there, we know that this task is too complex. So we need to lower the complexity of this task, and we need to provide scaffolding support so that the child doesn't need to rely on their strategies in this task. Okay, then at this point, we see another loss of quality. So this is what happens here. So that's sort of how the assessment goes. So then after the assessment, when they understand those different areas that their child is struggling with, they can apply those strategies at home. And then in our weekly sessions, we work specifically on those brain skills with the parents. And that's what therapy sort of looks like. It's hour-long sessions every week. For me, that is what has been working with the parents' capacity, with medical aids, with my capacity. That's sort of how it's been working for us.
Yeah, I mean, that makes complete sense. I think one of the other guests mentioned, when she justified how the parents kind of fit into the picture, is that you only get to spend an hour with the child, and the parents or the caregivers are there for the rest of the time. So almost like if you can empower them to be, these therapists, in a small way, that's in the best interest of the child. And I think that's exactly what you said now as well, which is amazing. And I think for any parents, like in therapy and stuff together, I think it's a key point, because until you can carve out that time or have that opportunity, the child is probably not gonna see that full effectiveness of the therapy, that they're going through. Is that a fair point?
Definitely. Yeah,
Okay.
definitely.
Cool. Yeah, I think we don't really realize it as parents, because there's so many other things. But yeah, it's not just like drop the child off for therapy and that's kind of it.
And that is what is common, Oliver. That's what we're seeing as the therapists. Like, parents are overwhelmed. They're working. Sometimes both the parents are working full-time jobs, and now as a therapist, we are requesting that they come to the therapy sessions. It's a lot for parents. We also understand that. Especially for me, working with special needs parents, often I think it's seen as like finally a break, I can just leave my child for an hour. So it's quite it's a tricky space to navigate with parents, because it's very important that they are there and they're understanding. But yeah, they have a lot going on. It's a long, hard journey for them.
I must confess, though, it's always an unfair comparison with parents when they drop their children off at OTs, because you guys have like such cool toys, and it's hard to even compare. And now the child has to come home. There's like no cool toys like the swing, the tunnels, and
OTs
all
have
of those
the best
things.
stuff.
Yeah, I know, it's amazing. It's like the perfect playground, for kids. Even the ball pit. I mean, like I would have never thought like a ball pit is like a big thing, but OTs have like a ball pit. It's incredible. In terms of the maze itself, as an OT, I mean, you mentioned like special training. Is there like a requirements thing, or is it purely that you have to get onto the training to be able to do that? And I suppose what I'm asking is like, how would an OT become, MAES trained? Is it a conscious decision, at some point when they say, actually, I want to work with CP type patients, so this is something I want to consider?
Yeah, so for to be a MAES therapist, an OT or a physio or speech therapist has to complete the 4-week training. So there's an introduction course, that's a 2-day course that's really helpful in just sort of understanding the basic principles of MAES, but it's not enough to sort of implement that knowledge and to understand it fully. So there's a 4-week course there's actually one happening at the end of the year in Cape Town this year.
Okay.
And it's basically 2 weeks is online. So it's from Monday to the following Friday. It's an online sort of 8 to 4, 8 to 5, or 9 to 5 sort of coursework where you are learning, you're getting theory, you're analyzing videos online. And then you have a 2-week break. And in that 2-week, you sort of have 2 projects or assignments that you do. And then you come back and you do 2 weeks of a practical in-person part of the course. And in that time, you have some time for theory and learning. And then you have a lot of time of actual therapy with patients, workshopping, practicing, understanding, and with kiddies that have neuro conditions, which is extremely helpful. So once you've completed that 4 weeks, you have to pass the MAES training, and then you are MAES, then you can be you become a MAES therapist.
Okay, that's actually really cool. And what spurred on the thinking? I mean, at what point did you decide actually you want to become MAES trained?
Yeah, so when I started working with children with cerebral palsy, I felt like I wasn't making a difference. Like I wasn't seeing change. I was playing with the children. It was awesome and fun, and I love my children. So felt like just loving them was enough. Like these kiddies often don't get out. They're not exposed to a whole bunch of things. And I thought, okay, this is fine. This is enough. But I wasn't seeing change in their quality of movement, in their function, in their participation. I wasn't seeing improvement. So I was just exploring different things, like what are the different sort of approaches that exist. And I came across the MAES website. I read testimonials from parents, and basically chatted to a few different therapists, and then decided, okay, this looks really cool. Like to see the parents giving this sort of feedback. This is something that I would like my parents to say. And that's basically why I signed up for it.
That's amazing. Yeah. I think what you said now, it makes a lot of sense. I think for parents, like looking at it, and also for therapists, but also, like almost having that introspection and saying, is this working or not? And I think, yeah, that is amazing that you went down that journey. It's actually very, it's a good testament of being that therapist, looking for that results. Speaking about the previous one, we were speaking about the parent input, and I think a speech therapist told us this as well. Like speech therapists, you think talking, and when the parents are dropping off their child, and after 3 months, and the child is still not talking, they just think, but what are you doing? Because I'm bringing the child, but they're still not talking. And she said, I think it was Marie Thiat, and she said, it's a lot of even the parents, they have to do the exercises and stuff like that. And speech is such a complicated thing. And I think what you're saying now is even you would think just OT, but as you said, this other approach, the MAES approach on it, brings out even better results, and that is pretty incredible to know.
Yeah.
And in terms of, I have to ask because of COVID and stuff like that, but did you find over the last few years, probably 2 years now, 2.5 years, during COVID, did your therapy change a lot, or did patients change a lot? Obviously the mask came on, but is there anything else around that you found quite peculiar or significant?
Yeah, so therapy with masks on was horrible. Really struggled with that. Obviously, being a pediatric therapist, you are working with children and they rely on your face, on your feedback that you're giving them. You rely on it to talk to them, communicate with them. So that was really hard. Also, a lot of our kiddies have secondary complications. They have weaker immune systems at times. Not all of them, but some of them can be quite sick. So I found that a lot of my parents said that they would rather hold off on therapy than continue it. And then we had a lot of regression in some kiddies. A lot of kiddies didn't leave the house for almost a year for that whole first sort of COVID stint, which had a massive impact on them. So it was like quite devastating to see that and to hear that. And I fully understand, you know, like where the parents are coming from and the concerns, and they just love their children. But it was really hard to know, you know, like what the kiddies were able to do now. They weren't able to do that. They're not getting the social interaction they were getting. They're not getting out. They're not getting a variety of experiences. They just are quite stuck. So that was like a big thing in COVID. What I know what Jean-Pierre found so helpful, like from a MAES approach, is that he ended up doing a lot of Zoom sessions, which he initially started off as extremely difficult, but then he found that it was actually so helpful. He could reach more people around the world, where the parents became the hands of the therapist, and he sort of directed them verbally, where to put your hands, what to do now, how to respond to the child in this. So he was watching what was happening on the screen, and then telling them what to do, which I think is incredible, like with Zoom. I did a few sessions like that, and I think I needed to practice a bit more, because for me, I didn't feel like it was helpful. But for him, when we analyzed the Zoom sessions, it was incredible to see what you could get from not just from a Zoom session, where we always think, you know, we have to be the ones that are using our hands, where he was empowering the parents so much and getting good results. So I think the COVID time was really, really interesting for a lot of different therapists.
Yeah, I think almost like, I mean, I'm completely in the camp of Jean-Pierre in terms of how you reach out. And I think for me, you know, when I look at therapists and how they've grown from embracing the technology and being online, even this session that we're doing now, you know, I think if we approached therapists probably 3-4 years ago, they would be a lot more hesitant. But now it's like one of those things, you know, like we just do, you know, we get on a Zoom session, or Teams or whatever, you know, like it is. But I think that's amazing. And I think from a technology point of view, we probably need to work more on the setup. You know, like cameras that move, as an example, you know, like webcams, so you can kind of see the movement, you know, and stuff like that. I think would make it even more amazing. And I think we probably
That
will
would
go
be
down
awesome.
that route, you know.
Yeah,
Yeah.
we're probably not far from it.
Yeah, I know. I used to be in these boardrooms, and they used to have these cameras. You know, like, and the camera would sit in the middle of the desk, and whoever's talking, it would automatically like swivel towards that. So it is
Oh,
available.
wow.
Yeah,
Yeah.
so it is available, but you know, obviously not cheap and stuff like that. But I think, you know, for parents, you know, if you could have that, even as a therapist, if you could have that view on the child doing the exercises, would be pretty amazing. You know. Yeah.
Yeah, that would be awesome.
We do want to wrap up. I think it's over an hour now, but I do want to ask, and this conversation was amazing. I mean, but in prep for the conversation, obviously we try to cover as many of the, you know, the things we see kind of coming up, you know, especially with people searching online. But is there anything around cerebral palsy or the MAES approach or MAES in general that I should have asked you that I didn't?
I think that, I mean, I could probably speak for a whole day on the topic. Like it's so complex, and because we're talking about the brain, there's so much information. I think like this is a really good starting point. You know, just covering the basics, which was really, really cool. I think there's a really good interview that Jean-Pierre did that's on Wired on Development, where he answers a few questions. So if people are wanting to know more about MAES and the approach, there's really good information from him on that interview. And just reading their website also has so many different answers for us. But I think, Oliver, you did a good job at asking good
Okay.
questions. So
Yes.
I think we covered the bases well.
Okay. And I think, I mean, I think every therapist says the same thing. Is like, I think our job in an hour is probably not to, or an hour and a half is not to cover everything, because that would be
Yeah.
arrogant. But it's more to just get the thinking going and saying,
Mm.
I remember Sam mentioned this, and I would really like to know more, and then reach out to you as an example, or another
Yeah.
therapist, or look at the resources. But speaking about that, I mean, if there's any books or resources online, um, or otherwise, that you want us to include in the show notes, or once we transcribe this, please let us know. We'll put that on. We'll obviously have your contact details as well. But I did think of one more thing. You mentioned you don't like the word tone, and I can't, that's going to bug me, sorry. But can you tell me why you don't like that?
Yes, I can. Could also talk for an hour about that, but
Okay.
I won't.
Mm,
So I think that we were trained to assess tone as a symptom. So you do a tone assessment and you say, okay, there's increased tone here. Then our treatment would be to decrease the tone or normalize the tone. So you work with tone, and the problem then becomes the tone. When we understand cerebral palsy from just even this chat now, we understand that the problem is on a brain level. So there's an injury to the brain. So the problem is not the tone. The problem is the message that's coming from the brain that's increasing the tension that we then see as increased tone. But it's important for us to say, why is it increasing at that point? Why is the brain saying to that muscle, increase the tension here now? And not saying, okay, if I just look at this muscle and I know that there's increased tone, how do I break the pattern, or how do I normalize the tone? Because I think then we're looking at it from a symptomatic approach, where I want to say, okay, why is the brain sending that message? What is happening on a brain level, and not the arm is the problem or the leg is the problem, the muscle, the tension in the muscle is the problem. No, the brain is the problem. What's happening there that's resulting in what we're seeing in the tone?
mm. I think you explained that perfectly. That that makes a lot of sense. Yeah, and very symptom based versus root cause analysis and trying to figure out what's going on underlying in the brain. I love it. I love this conversation. Thanks so much for doing this, and yeah, hopefully speak to you very soon on another topic.
Cool. Thanks so much, Oliver. That was, yeah, good conversation. Thank you.